Welcome to Performing Biopsies as a General Dentist, Simple Biopsy Techniques, and How to Bill for Them. This program is supported through an educational grant by Viva Learning and Purell Pharma. There are a couple of educational objectives for this. Number one, determine when to perform simple soft tissue biopsies, and more importantly, determine when to refer. You may not want to biopsy everything you see if you think that there's a malignancy involved. Objective number two, understand what special equipment, if any, is needed to perform a biopsy. The short answer is no, and we'll get to a discussion of that. Number three, how to receive reimbursement for both the oral cancer screening exam and for the biopsy procedure, both. Number four, how to select a pathologist to read the biopsy. Once you perform the biopsy goes to a pathologist who will then take a look at it and decide what the diagnosis is, if it's malignant, if it's benign, what treatment is necessary, and on and on and on. And number five, how to market this most valuable service to your patient base and how to bring in new patients into your office. This course will give you a very simple 5-step program to perform simple soft tissue biopsies in your office without buying any new equipment. Everything you need for the biopsy, except the biopsy jar, you already have in your office. And the biopsy jar is supplied to you by the pathology lab. So there's nothing you need to buy. We'll get into a little bit more discussion of that shortly. If you use this course like a cookbook and just follow the 5 simple steps, you'll know what to biopsy, where to biopsy, when to biopsy, and just as importantly, when to refer and how to biopsy. I've been teaching webinars and seminars and participation courses for a long, long time. And the best way to have dentists learn these techniques and technologies that I teach is just to give a simple cookbook. Step 1, step 2, step 3, step 4, step 5. Once you have those 5 steps down pat, you'll be able to do whatever you want. So, step 1 is patient assessment. Step 2, lesion assessment. Step 3, tray setup. Step 4, technique. And step 5 is post-op. That's it. 5 simple steps. So before we start, here's a question or two for you. What is a biopsy and why do we biopsy? So the textbook definition of biopsy is removal of a piece of tissue for microscopic examination. So the pathologist can take a look at it and tell you what you're dealing with. Why do we biopsy? To determine whether a lesion is inflammatory, systemic, or neoplastic. You see something in a patient's mouth, you're not sure what it is, you need to know what it is, you need to find out what it is, so you're going to biopsy it to find out what's causing it and what it is, and of course, how to treat it. So we've got an adolescent here with terrible home care and terrible gingival inflammation, and the tissue is red and hyperemic and edematous. This is not a cancer. This is not a neoplasm. This is not a tumor. This is an inflammatory response to the orthodontic wires and the accumulation of a great deal of plaque in this patient. Systemic. This is a 27-year-old white female, status post-kidney transplant. As a result of the kidney transplant, she's on 2 drugs. Number 1, cyclosporin, which is an immune system suppressant, that prevents the body from rejecting the transplanted kidney, and a calcium channel blocker to help maintain her blood pressure. Both of these drugs have as a side effect gingival hyperplasia. So this is a systemic result of medication that the patient is taking. Neoplastic. This is something we rarely see anymore, but in the 80s, we saw this far too often. This is Kaposi's sarcoma, which is a sarcoma, a tumor that was very, very common in AIDS patients back in the day. So this is a neoplasm. This is a cancerous growth in an AIDS patient. So why do we biopsy? Well, to determine whether a neoplasm is benign or malignant. So what's a neoplasm? new growth. That's all it means. So to determine whether something that you're seeing in the mouth that wasn't there before, is it benign or is it malignant? And if it's malignant, for the pathologist, not for the general dentist, for the pathologist to type it, grade it, stage it, and determine a prognosis for the patient and a treatment plan. Just excision, maybe radiation therapy, maybe chemotherapy, maybe any of a whole bunch of different possibilities. That's beyond the reach of a general dentist or most dentists. That's something for an oncologist to worry about along with the pathologist. So everybody sees this in private practice. This is a patient whose home care is less than ideal. She's got a calculus bridge, and her lower anterior lingual is where the calculus bridge is. And when her tongue rubs up against the calculus bridge, the tongue gets irritated. And this is nothing more than a simple irritation fibroma on the tip of this woman's tongue. Is it benign? If that's indeed what it is, the answer is yes. Do I know this is an irritation fibroma? No, I don't. I don't have X-ray vision. This could be any of 5,000 different things. However, what I want you to get from this slide is very often the medical history and the habits of the patient will give you a diagnosis. And the diagnosis is confirmed by the biopsy and pathology report. So seeing this patient, I would assume it's an irritation fibroma, but I would biopsy it and have the pathologist tell me for sure. I don't have X-ray vision. Malignant. You may remember from dental school that the palate, soft palate, hard palate, has lots and lots and lots of salivary glands. And you may also remember from pathology that there are plenty of salivary gland tumors. So this could be a benign salivary gland tumor, or it could be a malignant salivary gland tumor. Only one way to find out, and that, of course, is to biopsy. Now, what are you going to do with this? You're going to palpate it, of course. It doesn't look like it's a torus. It's going to be soft. It's going to be wiggly. It's going to be rubbery. So it's not something bony like a torus on the palate. So this is something that you will need to biopsy and determine what it is exactly. Most likely some sort of salivary gland tumor, benign, malignant, don't know. That's why we biopsy. So there are a bunch of different types of biopsies. Excisional biopsy and incisional biopsy are the two most common. Oral cytology is basically an oral version of a pap smear, where you just take some cells and you examine it under the microscope. Brush biopsy is a relatively new procedure, and aspiration biopsy is taking a needle and aspirating fluid from the lesion. But for the purposes of this little webinar, we're going to talk about excisional and incisional techniques. Those are the two most common and, of course, the simplest ones to perform. Excisional biopsy, you remove the entire suspect tissue. Whatever's there, you remove the entire thing. Simple, easy, one step, you're done. So there's something there, some kind of oma, fibroma, lipoma, this oma, that oma. Don't know what it is. It's some sort of growth. So we're going to remove the whole thing. Not a difficult thing to do, relatively easy. Incisional biopsy is we remove only part of the suspect tissue. We don't remove the entire thing. Why would we do incisional rather than excisional? So let's discuss that. Number one, the lesion may be too large to remove easily, so wait until you get the diagnosis. Because if you biopsy little pieces of a large lesion and it turns out it's benign, you may not need to remove it. Patient may be able to live with it. Or there are multiple sites. So you sample a few sites, a few different lesions before you remove the entire thing. So this is a patient that had this white patch from pterygomandibular raphe to pterygomandibular raphe, maxilla, mandible, floor of the mouth, all over. You would not sit this patient down and remove this entire lesion unless you know it needs to be removed. And the only way you would know it needs to be removed, once again, is via biopsy. So when you see something like this, you're going to take multiple biopsies, maybe a little piece from the upper right quadrant, a little piece from the upper left, a little piece from the lower right, a little piece from the lower left, because it's possible that the upper right quadrant lesion is benign, the lower right quadrant lesion is benign, the upper left quadrant lesion is benign, but the lower left may have some malignant cells. So you need to take multiple samples. Is there a specific way to do this? Yes, of course there is. If you take multiple biopsies, please label the bottles and put one biopsy in each specific bottle. If you're taking a sample from the number 3 area, put it in a bottle, label it number 3 area. Take it from number 14, label the bottle 14, etc., etc. That way, when the pathologist reads it, the number 3 area could be benign, 14 area could be benign, 19 area could be benign, but number 30 may show a malignancy. And if the bottles aren't labeled that this is where you took it from, you may end up having to either rebiopsy or just remove a very large lesion that otherwise would not have to have been removed totally. So I'm going to take an incisional biopsy here, right within that circle, and I have to orient the lesion, and I have to orient the biopsy, because the area superior to it may be benign, the area posterior to it may be benign, the area anterior to it may be benign, but the area inferior to it may be malignant. Don't know. That's for the pathologist to tell us. So we need to be able to orient the incisional biopsy. So how do we do that? We've got a superior, inferior, anterior, and posterior aspect to this. Well, we're going to take some sutures, and maybe we'll put 2 long sutures on the anterior section of that biopsy. Maybe we'll take 2 short sutures on the inferior portion of that biopsy. Maybe we'll have no sutures on the superior part of the biopsy, and maybe we'll have 1 long and 1 short suture on the posterior part of the biopsy. That way, when the pathologist does the evaluation, he can say, no, the superior is clean, the anterior is clean, the posterior is clean, but the area that had the 2 short sutures, that may have been malignant. So you have this orientation, so you know what part of the lesion is benign, what part of the lesion is malignant. When you do an incisional biopsy, you can do it one of 2 ways. You can take a narrow, deep wedge or a wide but shallow wedge. You always want to take a narrow, deep wedge. Narrow and deep is better than wide superficial, for the simple reason that there may be malignant tissue deep in the lesion that you'll miss if you go superficial. And take wide margins. And this I'm going to discuss again a little bit later on, especially if you're using a laser, if you're using radiosurgery, if you're using electrosurgery, if you're using anything aside from cold steel, anything that has the potential to char or affect the biopsy specimen, you don't take regular margins like you would with a scalpel. You take wider margins. You go a little bit further out. That way, if you accidentally use higher power settings, you're not going to affect the margins, and you won't affect the pathologist's ability to read the specimen. So you're going to take wider margins with electrosurgery, radiosurgery, and lasers, and anything similar to that. With blades, you can take more narrow margins. So dysplasia begins at the basement membrane. So you have to make certain you go deep enough to reach the lesion. So if I take a wide but shallow incisional biopsy, it's going to miss the lesion at the basement membrane. So this will give me a false negative. If I take a narrow but deep incision, that's going to go all the way down, and that's going to get to the lesion. So wide but shallow, no good. Narrow but deep, that's the way we want to go. So biopsy techniques. Once again, no need for any special equipment. You can use cold steel, a plain old scalpel, a 15 blade, Or if you have electrosurgery or radiosurgery in your office, that's fine. Or a punch. Plenty of dentists perform punch biopsies, or a laser. What else do you need? A suture kit. Anything to hold a needle and any type of suture material and cotton pliers, and that's it. Everything else you get from the pathology lab, the biopsy jar, the biopsy requisition slip, the FedEx label, and on and on and on. Biopsy techniques. What's the most important determinant regarding the choice of technique? Should I use laser? Should I use electrosurge? Should I use radiosurge? Should I use cold steel? Should I use a punch? What's the most important determinant of which technique I'm going to use? Stop right here for a minute. Oral pathologists hate laser biopsies and electrosurge biopsies and radiosurgery biopsies, right? No, that's not right at all. That's 100% wrong. What's the number one key to successful laser or radiosurgery or electrosurgery use when performing a biopsy? Training. If you know how to use the device, you will have no effect whatsoever on the biopsy specimen. And if you are really well trained, the oral pathologist won't even know if it was done with a blade or laser or radiosurge or electrosurge. Training is paramount. If you're not fully 1001% trained in that specific modality, then maybe you shouldn't be using it for a biopsy. You don't want to risk affecting the biopsy itself. So if you're trained incorrectly, this is what a biopsy report looks like from a laser dentist that was not trained all that well. This is the microscopic description. I'm not going to read the whole thing. I'm just going to read the last sentence. Marked artifactual changes secondary to laser excision are also seen. What does this mean? This means when the pathologist took a look at this lesion, he saw a lot of damage to the biopsy specimen because too much power was used with the laser. This is what a laser biopsy report looks like in trained hands. Once again, I'm not going to read the whole thing. Multiple sections so well delineated, blah, blah, blah. And it says nothing whatsoever about any artifactual changes. Why? Because this was done by a dentist that knew how to use the technology well. And as a result, there was nothing that affected the biopsy at all. Important. When using lasers, electrosurgery, radiosurgery devices, remember, take wider margins than usual until you're proficient with the settings so the specimen is not inadvertently damaged by use of excessive energy. Why laser? Gives you a bloodless field, excellent visualization of the field, decreased vulnerability to post-op infection, decreased scarring, no wound contracture, less post-op bleeding, less post-op pain, no need for sutures, no need for post-op meds. These are just some of the many, many reasons why a laser biopsy in many hands is preferable to a scalpel biopsy. But once again, at the end of the day, you've got to be fully trained in the device or technique that you're using. So we need to know what to biopsy, where to biopsy, when to biopsy, and when to refer. So what do we biopsy? Whatever looks suspicious. Red lesions, white lesions, bumps or lumps, macules, papules, pustules, nodules, and I probably just confused you with those four terms. A macule is a flat lesion. Papule is a raised lesion. A pustule is a raised lesion that has pus, and a nodule is a raised lesion that is firm and rubbery and solid. So these are things that you should biopsy because they're going to look suspicious. According to the textbook Oral Maxillofacial Pathology, which is one of the more common oral pathology textbooks, this is the top 53 oral pathologies in order of occurrence. Leukoplakia, which means white lesion, that's all. Doesn't mean benign, doesn't mean malignant, it's just a white patch. Palatal irritation, fibroma, Fordyce granules, which I'll show you in a minute. Tori, fibromas, hemangiomas, ulcers, and on and on and on. And you see the list. No malignancies here. Herpes, mucocele, scar tissue, angular cheilitis, smokeless tobacco, hematoma, frictional keratosis, like less. The 25th most common lesion that dentists see is a squamous cell carcinoma. That means when you look at lesions, the odds of it being cancerous is extremely remote. The first 24 types of lesions that you'll see are perfectly benign. So you don't have to worry about possibly getting involved with biopsying something that's malignant. And I'll discuss this more in a couple of minutes. What to biopsy? Lesions that don't respond to local treatment within 7 to 14 days. So there is a lesion on the cheek by tooth number 14, and you take a look at number tooth 14, and the cusps have broken and the cusps are really sharp. So why don't you just smooth down the cusps or restore the tooth and see if the lesion goes away? If it goes away, fine. If it does not go away once the cusps have been taken care of or restored or whatever, then maybe it's something to biopsy. Lesions that interfere with function. There's a little something on somebody's lip, and every time they eat, they bite it. That should be biopsied. Lesions that show sudden enlargement, sudden growth, things that like that need to be biopsied. Lesions that have no apparent etiology. It's there, you don't know why it's there. Lesions that are red or white or red and white. Lesions that are deviations from normal anatomy. Lesions that are hyperkeratotic. Hyperkeratotic, what does that mean? Nothing more than there's an excess amount of keratin there. Where to biopsy? Listen carefully. If your practice accepts assignment of insurance or works with insurance companies, this can be important. Ideally, since you are dentists, as we all are, we should be able to biopsy anywhere from the vermilion border all the way back towards the tonsils. Practically, that's not true, and we'll discuss this in a minute. Ideally, free gingiva, attached gingiva, tongue, palate, lip, buccal mucosa, these are all places that you should be able to biopsy. Warning, check with the dental insurance company first. Always call the dental insurance company. Always make certain it is on a recorded line. Demand that the conversation be recorded. Get the name of the person you spoke to, what office they're in. Write down the time of day and the day of the week, and say, I'm doing a biopsy on the lip, on the cheek, on the tongue, on a wherever. Will this be covered by your dental insurance plan for my patient? And they will tell you yes or no. Did you know that the tongue and the cheek are not part of the mouth, according to some insurance plans? There are some insurance companies that I deal with in New York that will not pay me to do a cheek biopsy or a tongue biopsy. But if I send the patient to an oral and maxillofacial surgeon who has the same DDS degree as I will, they'll be paid for it. Not fair, but that's the way some insurance company policies run. So, tongue biopsy, check with the insurance company first. Buccal mucosa biopsy, check with the insurance company first. Lip biopsy, check with the insurance company first. Free gingival biopsy, these are always paid for when a general dentist does it. Attached gingiva, always paid for when a general dentist does it. Palatal biopsy, sometimes yes, sometimes no. Check with the insurance company. So, where to biopsy? Free gingiva, attached gingiva, absolutely. Tongue, palate, lip, buccal mucosa, maybe, maybe not. If you're insurance dependent or you want to get money back for the patient, if you're not insurance dependent, please make sure you get this information. Ready for the 5-step program? Here we go. Patient assessment. Complete medical history can very often give you the diagnosis, and it'll help you decide if this particular patient is the right patient for you to treat. Assess the patient. Drugs used. This merits some discussion. What do you mean by drugs? Well, scenario number one, Mr. Average Guy. Mr. Jones, before we begin the procedure, you take any drugs? No, I don't. Not even aspirin or Advil? Oh, sure, I take those, but those aren't drugs. I mean, I don't get a prescription for them. I take a baby aspirin every day, and I take Advil for my arthritis. Well, the patient may be anticoagulated, may bleed a little bit more, so this may be somebody that you don't want to treat. Scenario number two, Mr. Healthy Guy. Mr. Jones, take any drugs? No, I don't. Any supplements? No, I don't. Anything in the health food store, the drugstore? Well, sure, I take ginkgo biloba every day so I don't get Alzheimer's, and a vitamin E capsule. Well, ginkgo biloba and vitamin E can have some anticoagulative properties, and this may be a patient that you may have trouble getting to clot. Adventurous chef, Mr. Jones, taking any drugs? No. Supplements? No. Anything from the health food store? No. Any hobbies? You like to cook? Oh, sure. I love to cook with lots of spices like garlic, turmeric, cayenne pepper, cinnamon, ginger. Well, each of these has very slight anticoagulative properties. Once again, may have trouble getting clotting. Mr. Honest Historian, Mr. Jones, before we begin the procedure, you take any drugs? Yeah, I take Coumadin or Eliquis or Xarelto or Plavix. When was your last blood test? Do you know your INR? Not sure. A few months ago. What's an INR? This is not a patient you want to deal with. This is a patient that may be anticoagulated, that you may not be able to get hemostasis. Mr. Honest Historian number 2, Mr. Jones. Yeah, I take Coumadin, Eliquis, Xarelto, Plavix. When was your last blood test? Do you know your INR? Well, my INR was last week. It always hovers around 2.5. Most people that are anticoagulated know their INR like they know their phone number. And patients these days have kits where they can take their INR at home, so they should know what their INR is before they come. INR is International Normalized Ratio. It is a figure that tells you how well the patient is going to clot, or if the patient is very anticoagulated. And it's something you should know before you do anything invasive on any patient. Is the patient a grinder? Look at the tongue. Any signs of macroglossia? Is the patient a cheek biter? Well, take a look. Do we biopsy this? Yes or no? This is nothing more than a prominent linea alba. We're not going to biopsy this. Sexual history, multiple partners, history of atypical pap smears with partners. Don't be uncomfortable discussing this. Human papillomavirus, which is associated with cervical cancer, is also associated with oral squamous cell carcinoma. And if there are patients that have had abnormal pap smears, that have had HPV, it is possible that they or their partners may end up with oral squamous cell carcinoma. Marsha Cross, for example, she was a star of Desperate Housewives, the TV show, and Melrose Place in Quantico. She ended up with anal cancer, and her husband oropharyngeal cancer, both most likely caused by human papillomavirus. So, Mrs. Jones, you know HPV contributes to cervical cancer, also contributes to oral cancer. So please make sure you have your pap tests on a regular basis. Scenario 2, Mr. Jones, you may know that HPV associated with cervical cancer can contribute to oral cancer. So please make sure, have a discussion with your spouse, your partner, about pap tests. Anything abnormal, I should know about. Know the medical history. Is that drug-induced gingival hyperplasia, or is there something else going on there? This is a patient that's a kidney transplant patient and taking cyclosporin and taking calcium channel blockers. So maybe this is simple gingival hyperplasia. However, there's a chance that this is leukemic gingivitis, because patients that are on cyclosporin have a slightly increased risk of leukemia. So this, we don't know if it's simple gingival hyperplasia or possibly leukemic gingivitis unless we do a biopsy. Know the medical history. Are those aphthous ulcers? Or does the patient have Crohn's disease or Poitsier-Graves syndrome or any of a half a dozen different GI disturbances? Don't know unless you biopsy. Is the patient an uncontrolled diabetic? That's not a patient I'm going to perform a biopsy on. Uncontrolled diabetics are going to heal very poorly. I don't need a patient healing poorly in my office. This is someone I will send to the oral surgeon. Is the patient immunocompromised? Once again, they may heal more poorly. I don't know that I want to deal with someone that's going to heal poorly. Send to the oral surgeon. This is a patient with human papillomavirus caused HPV, human papillomavirus, focal epithelial hyperplasia. So this is something that I would not feel comfortable biopsying. This is something I would prefer to send out to an oral surgeon. This was a patient in a hospital where I teach, so we did it with the laser and we just punched them out. We took great precautions. If the patient's pregnant, we tried scaling root planing, tried Paradex, nothing helps. What do? The patient's pregnant. Well, this is important. Take a photo and watch it until the second trimester. Anything special about taking the photo? Absolutely yes. Always have a perio probe in the photo so you know the measurement of the lesion. You're going to take the perio probe horizontally and vertically so you know the length and the width of this lesion so that you can tell when you take another photo 2 weeks later, has it grown or not, because you have your ruler in the field, the perio probe. And get written medical clearance faxed to your office, signed by the OB or by the nurse practitioner. In my opinion, not from a doula or midwife. That's my opinion, but you have to feel comfortable to perform the procedure. No epinephrine, etc., etc. Lesion assessment. If the board is completely visible, does the lesion start in the maxillary tuberosity and extend distal to the hamular notch? Well, that's going to be difficult for me to do. That I'm not going to do. That I'll send out to the oral pathologist. Can you avoid underlying anatomy? Is the lesion between the lower premolars? Well, how well do you know your normal anatomy? Where does the mental nerve exit the bone? Between the lower premolars. Do you want to incise near the lower premolars? Maybe not. You don't want to end up with nerve damage if you incise too deeply near the mental foramen. So I'm just doing an IND here, but this is an area I'd have to be very, very careful with because it is near the mental foramen. So this is an area that if I was to biopsy, I would have to take special precautions, make certain that I do not interfere or get anywhere near the mental nerve. Do you know what's normal and what's not abnormal? Do we biopsy this? Yes or no? No, we do not. This is geographic tongue, perfectly normal. Lots of people have this. Do we biopsy this? Yes or no? This is Wickham's striations, which is diagnostic of lichen planus. This is an autoimmune disease. This is something you can biopsy to make certain that that's what it is, but you cannot treat this by excision. It will come back because it's an autoimmune disease, but you can certainly get a pathologic diagnosis and you can ablate this and hope that it doesn't come back too soon. Biopsy, yes or no? These are Fordyce granules, which are nothing more than little sebaceous granules, very common in the mouth, not to biopsy. Will you be able to obtain hemostasis? Exsanguination in the dental office is no fun. That's a fancy word for bleeding to death. Can you obtain hemostasis easily? Once again, medical history. Is the patient taking any drugs, anything that can anticoagulate them? Is the lesion in a vascular area? This is a very vascular lesion, Kaposi sarcoma. So this is something you may have trouble getting hemostasis with. This is the palatal view of that lesion. Papillary hemangioma. Could you get hemostasis if you're biopsying a hemangioma? May be difficult. Midline of the palate, not very vascular at all. That's an area I can biopsy very easily. Further laterally, closer to the teeth, you have the posterior superior alveolar arteries and venules here, arterioles and venules. So this area here, I might send to the oral surgeon. But we biopsied it, and that's what we ended up with. Is it in a cosmetic area? Will you leave a scar? This mucocele is right on the border of the vermilion border of the lip. Past the vermilion border, I might create a scar, so you got to be careful. Large lesion, using a laser or a scalpel or whatever you want to use. You can go circumferentially around it, cut it out, let it heal by secondary intent, and you're all set. Simple, easy, not a big deal whatsoever. I am within the vermilion border, not past the vermilion border, so I'm not going to leave a scar, and that's what it looked like 2 weeks later. Could it be malignant? Fig rub. Fig rub. It's a mnemonic device I use to help me figure out if it's malignant or benign. F, fixed. The lesion is fixed to the underlying tissue. It's not rubbery and movable. It is fixed. I, indurated. That means it's firm to the touch. G, growth. It grows rapidly. R, red. The lesion is red or red and white. U, ulcerated. The lesion surface is ulcerated. B, bleeds easily. These are the 6 diagnostic criteria to determine if a lesion is probably benign or probably malignant. If it's fixed, it could be malignant. If it's indurated, it could be malignant. If it grows rapidly, it could be malignant. If it's red or white, could be malignant. If it's ulcerated, could be malignant. If it bleeds easily, could be malignant. Could be, not definitely. And I'll show you some examples. If it's benign, it may be painful because cancer, unfortunately, is not painful until it's really, really big. Pain usually means inflammatory, not malignant. If it's bilateral, it's usually anatomic, not pathologic. If there's fever, it could be viral or bacterial. And if there are multiple lesions, it's probably viral. Clues that suggest malignancy: sudden weight loss, sudden regional lymph node problems, swollen lymph glands, poorly demarcated margins. You can't tell where the lesion ends and the normal tissue begins. It kind of blends in. These are reasons to refer. When else do I refer? When fig rub turns out badly. Use fig rub with a bit of common sense. So this lesion is fixed. It's indurated. It's ulcerated. 3 characteristics of something malignant. Uh-oh. Yeah, this is just a maxillary torus with a pizza burn. So use your fig rub, fixed, indurated, grows, ulcerated, bleeds. Use this with a little bit of common sense. It's ulcerated, yes. It grew rapidly, yes. It's red and white, yes. 3 characteristics of fig rub. It's just an aptus ulcer. So use this with a bit of common sense. You should be fine. So when do I biopsy? As soon as I see something? Absolutely not. But it depends on what you think it is. An irritation fibroma on a tongue ain't going away by itself. So this is something I'll remove the calculus bridge and I'll have the patient come back in a couple of weeks. And if the irritation fibroma is still there, I will biopsy it. And if it's gone, wonderful. I saved the patient from a procedure. What else can we biopsy on this patient? Hemangioma on the lip. Tray setup. Biopsy jar, you get that from the oral pathologist. Gauze, you have in your office. Cotton rolls, you have in your office. Suture material, any type of suture material you have in your office. A regular mirror, tissue pickups, cotton pliers, a needle holder to hold the needle, obviously, scissors to cut the suture, a suction tip, a blade handle and a blade, and a marking stick. So this is what it looks like. We have the mirror. Instead of cotton pliers, I have something called Adson forceps, ADSON forceps. They're a little fancier than cotton pliers. Needle holder, scissors to cut the suture material, suction tip, 15 blade and handle, suture material of choice, cotton roll, gauze, and the biopsy jar. The biopsy jar is supplied by the oral pathologist. Anesthetize. Outline the lesion in your mind and color it with a marking stick. Grab the lesion with pickups, or what I like to do is put a suture through it rather than holding it with pickups. Excise the lesion, ensure hemostasis, and post-op instructions. When you anesthetize, block is preferred over infiltration, because if you infiltrate too closely to the lesion, the solution can distend the tissue and mess up the diagnosis for the pathologist. And if the solution is deposited irregularly, the laser, the electrosurge, the radiosurge, the scalpel may cut irregularly because there's an area that may have too much liquid and then an area that doesn't have enough liquid, so it will cut irregularly. If you must infiltrate, inject at least 1 centimeter away from the lesion. Once again, you don't want to get too close because that could mess up the pathologist's ability to read it. Use a denture marking stick. These have been around since probably the 1800s or 1900s. So it's a little blue marking stick. You wet it under the tap or from the 3-way syringe. They're usually used to mark denture sores so you can relieve the denture, but you can use it to mark the borders. So here's my perio probe. I've marked the border. And now I'm going to go ahead and do the biopsy. How do I know where the margins are, though? How do I make certain I outline the margins correctly? Fluorescence visualization. So how do we do a better job of early detection? Fluorescence visualization helps. There's something called goggles, glasses for all cancer curing light exposed screening. It's a pair of glasses that will filter out certain wavelengths of light. And when you shine your curing light on a lesion, it can let you know if it's most likely benign or not, if it's something that needs to be biopsied or not. These are the glasses. So once again, early dysplasia starts at the basement membrane. You can't see it, but the fluorescence visualization can. I don't want to get into a whole discussion about how fluorescence visualization works. There's plenty of literature on this in the dental literature and in the medical literature. It's just basically that different tissues fluoresce at different rates. Benign tissue will fluoresce at a different rate than possibly malignant tissue. So you can see this is a fluorescence visualization on the top right. You don't see the lesion on the top left. Toluidine blue shows the lesion but doesn't show the extent of the lesion. Toluidine blue missed this lesion completely, and it was severely dysplastic. So these goggles, among other devices, work really well to help diagnose. You think this is a little fibroma? Well, with the fluorescence visualization, it ended up, upon biopsy, being carcinoma in situ. So this is the way a surgeon would use the fluorescence visualization. We've got the lesion. We're going to mark it with our denture marking stick. We're then going to see with the fluorescence visualization that the lesion is actually larger than it looks like. So we're going to change our margins. If the lesion fluoresces normally like the surrounding tissue, it's probably nothing more than a cheek bite or a lip bite. If it fluoresces differently than the surrounding tissue, it's something that needs to be biopsied. You know, there's an ADA code for using these devices. Big deal, there's an ADA code. Let me see my return on investment. If you charge $50 for this, and the cost of the unit is $1,200, your one-year profit is almost $50,000. $50,000 minus the $1,200. Your two-year profit is almost $100,000. If you charge $100, your two-year return on investment is $200,000. You charge $150, your return on investment is almost $300,000. This is assuming you do 1,000 a year. Can we do 1,000 a year? Sure. If we work a 4-day week, not a 5-day week, 6 patients a day have this. That's 24 patients a week. That's 96 patients a month. You only work 10 months a year, take 2 full months of vacation. That's 960 exams. So you can get to 1,000 easily enough if you market this correctly, which we'll talk about in a minute. With the ADA code in New York City, my experience with insurance plans that I work with, Guardian and MetLife will pay up to $150 every 24 months on patients 40 years of age and over that have this performed. Some Aetna plans do, some Cigna plans do, not all Guardians or MetLife, some of them do. I have yet to find a Delta Dental or Blue Cross Blue Shield Anthem that does. So some insurance companies do, some don't. Check with the insurance companies. So when you perform the biopsy, and you should, you get paid a very nice fee for the biopsy as well as the fluorescence visualization exam, because there's an ADA code. So the simple 2-minute exam and biopsy, you get 2 fees, one for the exam, one for the biopsy. Gordon Christensen's clinical report back in 2012 said fluorescence is a part of oral cancer screening because it reveals abnormal cells before they may be noticed visually. It promotes thorough exam, and cancer screening must be a routine part of oral exams. So this is something that Gordon Christensen and CRA really talk about and promote. Using these devices can save somebody's life. Do these things actually work? Well, if insurance companies are paying for it, it has to have merit. How many dental insurance companies are you aware of that pay for procedures that are useless? The answer, of course, is none. Critical point. The Journal of the American Medical Association, not the Journal of the ADA, the Journal of the AMA, said the use of fluorescence visualization significantly reduced the rate of local recurrence in oral cancer. So these things work. There's plenty of literature about it. I don't want to waste my time doing a literature review, but there's plenty of information about it. How do we select a pathologist? Use only an oral pathologist. Call your local dental school, ask your friendly oral surgeon, call the American Board of Oral and Maxillofacial Pathology, find an oral pathologist, and you'll call them up. They will send you the kits that you need, and you do the biopsy, send it to them, and they'll send you the report. How do we market this valuable and life-saving service? Simple. Let Michael Douglas help you. This was the headline of the New York Post when Michael Douglas admitted he was a sex addict and ended up with oropharyngeal cancer as a result of having oral genital sex with a high-priced Manhattan hooker who had HPV in her reproductive tract. So let's listen to Michael Douglas.
In a world where cancer is almost a daily part of the news, one cancer isn't heard about enough. Oral cancers are increasing in the U.S., and as in my own case, most people know little about them. Like many, I thought that this was a cancer that impacted much older people who had used tobacco most of their lives. While that's still a problem, the fastest growing segment of the people developing oral cancers are young non-smokers. A very common virus, one responsible for the vast majority of cervical cancers, is now identified as a cause of this rapid rise in oral cancers. Thankfully, in a fast, inexpensive, and painless visual and tactile screening, a medical or dental professional can often identify early-stage disease. So please, the next time you visit your dentist or your medical doctor, ask for this simple screening. Finding oral cancer in its earliest stages may save your life.
How powerful do you think that is? Do you have this running on a continuous loop in your waiting room? You should. Do you have this running in a continuous loop in your hygiene rooms? You should. You can download this for free from the Oral Cancer Foundation. You can download it for free from YouTube because it's a PSA, a public service announcement. And you should have this throughout your office so that people can see this every single day. You can talk about mammograms, sonograms, pap smears, HPV, colonoscopies, occult blood, prostate-specific antigen, helical CTs for lung cancer. These are all procedures. These are all things that can find cancer early. We've got something that can find potential oral cancer early. It's this device. If the Boy Scout troop, the high school choir, the local church is having a fundraiser, take your goggles or your oral cancer device and do free oral cancer screenings. Great way to build your practice. Send out a press release to the local newspaper, the local penny saver. Talk about oral cancer as the 6th leading cause of death of men in the United States. There are more oral cancer cases per year than cervical cancer, ovarian cancer, pancreatic cancer. More people die from oral cancer than from cervical cancer or melanoma. Where I am in New York, it's almost 8 o'clock. I got up at 6 o'clock in the morning, so I've been up for 14 hours. How many people in the United States died of oral cancer since I got up at 6 o'clock this morning? The answer is 14. One person every hour of every day dies of oral cancer in the United States. So this isn't something rare and exotic. This is a real problem. Oh my goodness, I found something. What do? I don't want to get involved with biopsies. What if I do something wrong? Well, that's not a problem. If it's benign and you got it all, or benign and you didn't get it all, or malignant and you got it all, or malignant and you didn't get it all, 4 possible outcomes. If it's benign and you got it all, congratulations. Give yourself a pat on the back. Are you done? Absolutely not. You recall the patient periodically to make sure it doesn't recur. If it's benign and you didn't get it all, are you done? Absolutely not. You discuss with the pathologist to see if it's something that needs to be removed totally or it can be left and just watched. Malignant and you got it all. Give yourself a pat on the back. Are you done? No. You refer the patient to a head and neck surgeon. Malignant and you didn't get it all. You refer the patient to a head and neck surgeon. So no matter what it is, you have no liability. The only liability you have is by not doing the biopsy or not referring the patient for a biopsy. Post-op treatment, post-op instructions, fill out the biopsy report for the lab, examine the wound, remove any sutures, review the pathology report. Remember, benign report doesn't mean the job is finished. I'm running out of time. Just bear with me. Just a couple more slides, then I will take questions. Whether benign or malignant, discuss it with the pathologist. If it's benign, do you remove the rest of the lesion? I don't know. That's for the pathologist to tell me. Benign idiopathic white lesions have a malignant transformation rate of 17%. Do I leave it? Do I watch it? Do I remove it? I photograph it and I discuss with the oral pathologist. And if I see that it has changed from one photo to another, I have another discussion with the oral pathologist and will probably repeat the biopsy. Recall the patient periodically to ensure that the lesion does not recur. If it's malignant, refer to an oral maxillofacial surgeon or a head and neck surgeon. Insurance codes. There are insurance codes for excisional biopsies, for incisional biopsies, for different size lesions. They're all ADA oral surgery codes, 7,000 section codes. And there are many references to change the ADA codes to medical ICD and CPT codes. This is a pathology report, and it tells me the CPT, the ICD, and all of the information I need to send this to medical insurance. Almost done. Hang on. Then I'll get to the questions. Simple biopsy. So give me a minute. Sorry, that biopsy is not going to show up. Okay. If you have any questions, I am ready. So, questions and answers. First of all, here's my information. I use a laser. My name is Bob and I'm a DDS. So my email address is laserbobdds, and you can find me at fullspectrumseminars.com. I use a laser. My name is Bob and I'm a DDS. Simple to remember my email address. Please contact me with any questions you may think of after this is over. So, Eliquis is not tested with INR. You're absolutely right. My mistake. You're 100% right. What to do with leukoplakia, 10 by 15 millimeters, 6 months, that recently ulcerated, excision or incision? That's a great question. The answer is it depends how experienced you are with performing biopsies. 10 millimeters by 15 millimeters is a nice size. Where is the lesion? If it's in certain areas, 10 by 15 may take a little while to heal. If it's in another area, it may heal a little bit more easily. So basically, 10 by 15, it's based on your experience, what kind of experience you have with biopsies. Once diagnosed and biopsied, how often do these patients have to be monitored? Great question. I have these patients on a 3-month recall, and I make certain that they come in their 3-month recall, and I have it in my computer. I have a little list, and if they do not show up for their 3-month recall, they get a phone call, because I do not want anything to sit and sit and sit and grow, and the patient doesn't come in for 6 months, 7 months, 8 months, 9 months. That can be a problem. Okay. What other questions do we have? Okay, it looks like I may not be able to get to that biopsy, but we've got other questions. Is brush biopsy recommended? Most oral pathologists do not like brush biopsy for a couple of reasons. It doesn't always get deep. Remember, I said a narrow, deep wedge is better than a wide but shallow biopsy. And these brush biopsies usually do wide but shallow rather than narrow but deep. So brush biopsies pathologists generally don't like, and there's a possibility of missing. So that's my 2 cents worth. Let's see what else we have. Okay. For some reason, I cannot get to the other questions. Okay. Okay. Hang on, I'm getting to the other questions. Okay. Leukoplakia, the 10 by 15 is on the cheek. Once again, if you've done plenty of biopsies, I would go ahead and do it. If you're not all that well versed in biopsies, I would refer. If I have referred a patient to oral surgery and they do not go, what do? The way I do it is if I find something and they need to see an oral surgeon because I'm not going to do it, the patient sits in the waiting room or stands at the front desk, and I call the oral surgeon right then and there, and I have the patient get on the phone with the oral surgeon right then and there, and they make the appointment while I am standing there. And then basically it's up to the oral surgeon to make certain that they go. Sometimes people will put their head in the sand and deny that it's possibly cancer, and they don't want to have a biopsy. They don't want to face the truth. But you're obligated to make certain that they show up. What you can do on your chart, of course, is say patient referred to oral surgeon. We call the oral surgeon to make the appointment for the patient, or we gave the referral card to the patient, or however you want to word it, but make sure it's documented on the chart that you told the patient they must go to the oral surgeon. And I would absolutely, positively, unquestionably follow with the patient a couple of days later, a week later, to make certain that they have gone to the surgeon. Okay. We have a pediatric dentist. This held your attention. We'll be rewatching. Great presentation. Thank you very much. For a pediatric dentist, I'm just going to give you a little heads up. One of the things that pediatric dentists hopefully do is work on 2, 3, 4, 5-day-old babies. This morning I did an 11-day-old baby to release a tongue tie. So if you're interested in tongue tie release, working on 2, 3, 4, 5-day-old babies, please shoot me an email. Once again, I use a laser. My name is Bob. I'm a DDS, so Laser Bob DDS, and I can tell you about my tongue tie courses. My next one is going to be in London, the beginning of June. I have one in New Jersey, the beginning of July. I have one in Virginia in September. So there's a bunch of places where you can come. So once again, if you're interested in tongue tie release, 2, 3, 4, 5-day-old babies, shoot me an email. Okay. Do I biopsy pigmented lesions on the hard palate? It depends on the patient. If the patient is a smoker and it looks like nicotinic stomatitis, then the odds are I would probably biopsy it once, take a picture, and every time the patient returns for their recalls, take another picture, another picture, another picture, and compare the pictures. And if there's any change in texture, any change in color, any change at all, then I will make certain that they head right to the oral surgeon. Okay. What about punch biopsy? Any tips? I generally don't like punch biopsies. That's just my personal preference. I use lasers 99.9% of the time and scalpels 1% of the time. So if you are proficient with punch biopsies, that's fine. I am not proficient with punch biopsies, so it's not a technique I would use. But if you're trained, you know how to use them, absolutely, positively nothing wrong with them. What laser do I use for biopsy? That is a 3-hour lecture on its own. Please email me, and I will give you all of the information about what laser I use for biopsies. I use the same laser that virtually 100% of oral and maxillofacial surgeons use when they do biopsies. But once again, that's another lecture for another day. Please email me. Please call me. Contact me, and I will give you the answer. And any other questions? Because we are coming upon 8 o'clock. It is 7:59. So anything else? Okay. So it looks like we are just about done, 1 minute early. So thank you very much for listening. And if there's anything I can do, once again, shoot me an email. Go to fullspectrumseminars.com, but best thing is shoot me an email and I will get in touch with you and answer any questions you have. Anything else? Last minute? Looks like there's a couple more questions coming up. Oh, just thank yous. My pleasure. So hopefully I will see you at a laser course or a biopsy participation course. I give biopsy participation courses all over the place. For any of you that are in California, I will be at the California Dental Association meeting in a couple of weeks in Anaheim, giving a couple of courses. So maybe I will see some of you there. but hopefully I will hear from some of you. Okay, it looks like our time is up. So once again, thank you so much. I hope you enjoyed it. And hopefully I will hear from many of you, and I will see you soon. Have a great day. Bye-bye.